Hi, welcome to AATS Mitral Conclave 2017. I'm Dr. Randy Martin. I'm joined now by one of our esteemed colleagues from France, John Francois. Thank you so much for joining us.
Thank you.
It's great to have you here. So you obviously are a very experienced cardiothoracic surgeon, but you've also been very engaged with the beating heart trans-apical neocord. Tell us a little bit about that.
I think it's very important for the surgeon to be involved in all those new innovations.
Absolutely.
And particularly this one, because this one is done through a thoracotomy, a small thoracotomy, a minimally invasive approach on the left side, and it belongs to the surgeons because it has to be kept by the surgeon, and the technique for the technique, we introduce a device inside the apex of the ventricle, and we have to catch the free edge of the prolapsus leaflet, and then you can control by pulling on the cortex and looking at the echo if we have a good coaptation. And this is the goal. It is really simple on the principle. It's a little bit more complex to work, to do it.
So Jean-François, who is the ideal candidate? Is it a P2 prolapse, a foil P2?
Yeah, it's almost like the general surgery, thoracic surgery. I mean, the P2 prolapse, it's easier to repair. It's through a sternotomy, through a mini-invasive approach. It's also the case for the neocords and the apical approach. And the ideal candidate have to have a lot of tissue, in order to create a good coaptation. But as soon as you have more complex lesion, including the commissures or calcification or whatever, this is the limit of this technique. So if we want to get good results, we have to concentrate on the best indications.
What about atrial fibrillation? In other words, not a problem?
Not a problem. We can do both. Mostly our patients are at the early phase of the mitral valve disease because otherwise they have enlarged annulus, which is not the most suitable situation. And for this very reason, very few of them are on atrial fibrillation. But if there is, it's not a limit.
Like that,
yes,
not
it may
a problem.
happen, yes.
So what do we know right now with the number of procedures that have been done? The success rate, the durability?
The success rate is highly predictable, and it depends on the assessment. And we know exactly what are the good candidates. If you have not a too much enlarged annulus and a lot of tissue and lesion involving mainly P2, the quality of the result is probably as efficient as what we have during classical surgery.
Really?
But if you select the patient, of course, is for some reason you have a high-risk patient, you don't want to go for surgery, and the indication is not that good, you have to accept the suboptimal results. But this makes sense.
And the durability? Do we have? I know you've got.
We have not enough follow-up to speak about
but
durability.
Initially, it looks like if you leave the procedure room with very little MR, that it persists that way? I mean,
so far it persists, but the first in-man has been done in 2009, so we cannot discuss about long-term follow-up, of course.
And is it single or multiple neocords, or does that depend upon the pathology?
We use at least 3. It is recommended at least 3 neocords, because if you use only one, the forces applied on one is too much, and you need to spread the forces on multiple chordae, and also to grasp all the line of the prolapses of P2. If you have a large P2, it's more important to have several chordae distributed all along the free edge.
Super. So you make a small apical incision. Patient is in the hospital for what, a couple days? Or?
Yes, the goal is that. But so far we try to keep the patient 5 days. But we can expect to do it in a short time.
The obvious question is, will this always be a trans-apical approach, or do you think there will be?
No, obvious not. It is obvious not. This is just for a period. We know that. But the complexity to have a totally percutaneous approach and with a good anchoring is a strong limit, and probably we will have to wait for years before we have the complete neocord procedure available through a transfemoral approach, for instance. And this is, for the surgeon, a very good opportunity because they have to keep this new technique in the hands from the early beginning, because so far only surgeon can do this technique.
I agree wholeheartedly. I mean, I'm involved in a lot of transcatheter therapies. I think the surgeon knows the mitral space and really understands that. So let me ask you, where do you think we'll be in 10 years with transcatheter therapies for mitral valve disease?
I think it will take a large part of the mitral valve surgery.
You think it'll be very active then?
Very active, obviously.
That's interesting.
For sure.
That's interesting.
It will represent, well, it's difficult to say.
No.
It's more complex than what we have had for the aortic valve, which is much easier to replace. But anyhow, I think it will, this technique is here to last.
No, I don't think there's any doubt. I mean, I always stress durability of repair, the durability, and I think certainly with the technologies will improve and the durability of repair will
but we can also say that even if those techniques, the durability is not as good as with surgery, we can even imagine that we can reoperate the patient for a more traditional surgery or repeat the percutaneous procedure. But this is just speculation and we have to wait for...
Well, listen, you've done, thank you so much for educating me and educating our audience, and thank you for being a leader. And as I said,
what is important to know also is that we are now starting 2 prospective randomized studies.
Okay.
So we will have, within the next 2 or 3 years, evidence-based medicine to support or not the quality of these procedures. And this is very important.
Thank you so much. I mean, you've really educated me, and I've learned a lot, and this is very exciting. And thank you for joining us. I hope you'll come back.